I think we can start.
Yes, sir, we'll start. Dr. Bipla, you can introduce yourself and start the case.
Yes, ma'am. I'm Dr. Viplap Pal. I am presenting a case on varicose vein.
Modi sir is also
Yeah.
here. Good evening, sir.
Good,
Please start
Hello,
the
Dr.
presentation.
Modi. Good
Actually,
evening, ma'am.
my
Good
patient is
evening.
a 29-year-old male from Uttar Pradesh, machine operator by profession, presented with chief complaint of dilated veins in the right leg for 3 years and dilated veins in the left leg for 1.5 years. History of present illness. Patient was relatively asymptomatic 3 years before, after which he developed dilated veins on inner aspect of right leg, which was gradually progressive to inner aspect of right thigh and posterior aspect of right leg over last 3 years. Patient also complains of dilated veins in inner aspect of left leg for 1.5 years, which appears 1.5 years after appearing on the right leg and is gradually progressive. Veins become prominent towards the end of the day and gradually disappears on lying down in bed in bilateral lower limb. No complaint of pain, trauma, fever, limb swelling, prolonged immobilization, itching, skin discoloration, bleeding or ulceration. Past history.
Just hold on. Viplab, just hold on.
Yes, ma'am.
Uh, you have mentioned in the very first row that patient was relatively asymptomatic. I think
Yes,
you're
ma'am.
unnecessarily creating a bit of trouble in the sense if I want, I can just ask you that relatively means was he somewhat symptomatic? So don't use such words when you're presenting the case.
Yes, ma'am.
This doesn't apply only to this particular case, but for any case.
Yes, ma'am.
Okay, go ahead.
Past history. Patient has no history of intervention or operative history, no history of diabetes, hypertension or tuberculosis. Personal history. Patient has mixed diet, adequate sleep, bowel habits are unaltered, bladder movement unaltered, and no addiction. No significant family history. Summary of history. A 29-year-old machine operator by profession presented with complaint of dilated veins over right lower limb for 3 years and left lower limb for 1.5 years, which aggravated by prolonged standing and relieved by lying down with no history of any intervention.
Would you like to ask any additional questions pertaining to his past history? You have
Ma'am,
told us that he has not undergone any intervention.
yes, ma'am.
Hmm.
I
Anything
would
else?
like to ask if patient has been any history of prolonged immobilization is there or not.
Hmm.
If a history of any trauma is present for
Hmm. Hmm. So trauma, immobilization, and any surgery,
yes,
not
ma'am.
necessarily venous surgery, any surgery
Any
for
lower
that.
limb surgery or
So you should
pelvic.
tell us that. Huh?
Yes, ma'am.
Hmm.
Should I continue?
Yeah.
General examination. I have examined the patient with informed consent with adequate light and exposure in different position as and when required. Patient is alert, conscious and cooperative, fairly built and nourished. BMI is 31 kg per meter square. Temperature is afebrile, pulse at 86 per minute, regular in right radial artery. Blood pressure 130 by 70 millimeters of mercury in right arm supine position. No pallor, icterus, cyanosis, clubbing or edema. No generalized lymphadenopathy. Inspection. I would like to examine the right leg first. On right side, there are multiple dilated tortuous vein over medial aspect of right leg with foot, lower thigh and posterior aspect of right leg. Skin pigmentation with wasting of muscles present around the ankle. No swelling, scar, redness or raw area seen. No visible swelling or cuff impulse in groin. No brittle nails or loss of hair. Gait is normal. On left leg, multiple dilated tortuous vein over medial aspect of left leg and foot.
I I would suggest that you stick to one leg. Do you agree, Dr. Modi?
Yeah, madam. First, tell only
Because,
one leg.
yeah.
Yes, sir. Yes, sir. On palpation, on right side, temperature is normal and no tenderness. Limb girth is 41 centimeters in mid calf region. And Brody Trendelenburg test 1. There is rapid filling of column of blood from above downwards on releasing tourniquets, which is suggestive of right SFJ incompetence. And test 2, gradual filling of blood from below upwards in below knee perforators, right void perforator incompetent. In multiple tourniquet test, filling of vein visible at site of below knee perforator. Modified Perthes test is negative. Test for saphenofemoral junction is saphenopopliteal junction is competent, and lower limb pulsations are normal.
How
On-
did you do Trendelenburg's test?
Ma'am, first I will make the patient supine and then elevate the limb for milking of the veins and emptying of the veins. Following which I will place a tourniquet, or I can do it with the help of my thumb to occlude the saphenofemoral junction. And then
Hmm.
for test one, I will tell the patient to stand up, and I will, with the tourniquet tied or my thumb on the saphenofemoral junction, I will see if there is any feeling of blood from above downwards on releasing tourniquet.
Before releasing tourniquet, do you look for anything? Or before removing your thumb? And
If
where do you place your thumb?
I will place my thumb in the saphenofemoral junction,
Where?
4 centimeter lateral and below the pubic tubercle.
Hmm.
I will see if there are any blowouts or prominent veins present.
After releasing the tourniquet?
Before releasing, there are
Hmm.
immediate blowouts or not. And after releasing the tourniquet, I will see the direction of flow of blood from rapid filling of blood from above downwards, which is suggestive of
So
saffron.
if you do see filling up of veins before releasing the tourniquet, then you have to repeat the whole test again for looking at the after release what is happening, isn't it?
Yes, ma'am. For the test 2.
So you have to repeat the procedure again.
Yes, ma'am.
So what does the first uh, part of the test tell you?
The first part tells about the right of the saphenofemoral junction incompetence.
That was with your thumb or tourniquet on, isn't it?
Yes, ma'am.
So did you see any filling of veins
Yes, ma'am. There is a rapid filling of blood from above downwards direction.
after removing the tourniquet?
Yes, ma'am.
Okay. And then,
For the test two, I will repeat the similar procedure of making the patient supine and elevation and milking the veins, following which I will
hmm,
apply the tourniquet and then tell the patient to stand up.
hmm.
And then I will see there is gradual filling of blood from below upwards, in which area there is filling of blood is occurring with the tourniquet kept there.
No,
Hmm.
Dr. Pal, how do you, where do you tie the second tourniquet? Test two tourniquet, you said.
So at the saphenofemoral junction, below the saphenofemoral junction.
He's talking about Brody Trendelenburg's part 2.
Yeah, but how can he write down void perforate incompetent?
Yeah.
There are two other, there is dot perforator, there is void perforator. How do you know which of them is there?
So the direction
And
of blood flow was from below the
and
knee.
from below, and if you tie a tourniquet, that is what I'm asking you. Which place you tie this tourniquet in test two?
So in Brody Trendelenburg test 2,
Here you have written, yeah, Brody Trendelenburg test 2. Where do you tie the tourniquet?
at the saphenofemoral junction.
So how do you know it is not in the leg perforator? It is only void perforator which is incompetent. I think it's very difficult to say.
Yes, sir.
If it rapidly fills up from below upwards, there could be a perforator in the leg also, Cockett's perforator or any other perforator. It is very difficult to say. Where is void perforator, Dr.
So,
Pal?
so below the knee, 2 to 3 centimeter below the knee.
Hmm. So there are other perforators in the leg.
Yes, sir.
So how do you know which perforator is where? So it can be any other perforator. There are multiple perforators, na?
Yes, sir.
Yeah.
So which of these
So
tests
you,
tells you which perforator is probably incompetent?
Sir, ma'am, by doing the multiple tourniquet test, we can
Okay.
tell which perforator is incompetent.
Okay. I'm sorry about that, but going back to what you told us on inspection, You said that there is wasting of muscles at the ankle. Now, which
Yes,
are these muscles at the ankle which undergo wasting?
ma'am,
Can you name them?
soleus and gastrocnemius.
But are they at the ankle or the calf?
Yes, ma'am. Calf.
They're calf muscles.
Yes,
Huh? There are no muscular bellies that you will see wasted at the ankle. Huh?
yes,
What
ma'am.
you look at is the calf.
Yes, ma'am.
And why
And
calf
then
muscles should undergo wasting? In which conditions will the calf muscles undergo wasting?
Ma'am, if there is immobilization,
Hmm.
in that case, the muscles may
no, it related to varicose vein.
due to chronic inflammatory and fibrosis in lipodermatosclerosis.
Is
There,
lipodermatosclerosis related to muscles or is it related to skin and subcutaneous tissue?
ma'am, skin and subcutaneous tissue.
Then, so unless you are sure what you are talking about, please don't uh, mix up your words. That creates a completely different impression about what you're trying to do. Okay?
Yes, ma'am.
So I would say, Dr. Pal, that wasting will occur in soleus and gastrocnemius. You are right, but only if the patient has an ulcer in the ankle and he does not use the ankle pump.
Yes,
There is equinus deformity, there is fixation of the ankle joint. Then maybe there will be wasting. But otherwise, it's very difficult to explain, as Madam said, in ankle region.
yes, sir.
Okay.
Go ahead. Why are you doing Perthes test?
Ma'am, I'm doing Perthes test to check for the patency of the deep venous system if the patient is having deep vein thrombosis.
Huh?
देखिए हमारे का तेरे से मागं असं इकडे गेलं ना की लगेच ते सगळे थांब
No
तुम्हाला
patient
त्याकडे
with
दिसतं
acute DVT will be
वरती
kept
आलं
for
असेल सगळ्यात वर
for exam. Huh?
Yes,
So what does Perthes test tell you? We are seeing somebody else here. Bharat Kakade.
I mean,
Priya? Yeah, now I can see Viplav.
yes, ma'am, in modified Perthes test, we can tell about the deep venous system and if there is chronic venous insufficiency due to thrombosis or if varicose vein is there because secondary to any post-thrombotic limb.
So what happens when you do Perthes test?
Modified Perthes test, um, keeping the patient standing, I will apply tourniquet in the saphenofemoral junction and then I will tell the patient to walk for a few minutes, following which the veins may remain the same or may become prominent if it is positive.
Is that the outcome of positive Perthes?
That's
What
the only
else
thing.
happens?
Patient will have pain along with the prominent.
So patient gets pain. Patient can't walk. Why
Yes,
does the patient get pain?
because the deep venous system is blocked. So
So,
and we have also blocked the saphenofemoral junction. So the blood will not flow from the superficial or the deep system and there will stasis of blood in the lower.
hmm. And what happens? The venous pressure increases, isn't it? There is
So
significant venous hypertension.
so
That's
there
why
is
the patient gets pain.
outflow obstruction.
Yes.
Okay.
On percussion, on right side, Swatch test is positive and auscultation, no bruit heard. Systemic examination,
So what does Schwartz test tell you if you get it positive?
there is a dilated vein and there's a column of blood, stasis of blood in that dilated vein. And
Dilated vein with non-functional valves.
Well,
So there is no breaking of the column of blood. That is why you get Schwartz positive, no?
yes, ma'am.
If there was a valve which was competent, you will not get Schwartz positive.
Yes.
Hmm.
Ma'am, should I discuss the left leg?
No,
Yes.
just
Systemic
this one
examination.
leg.
On abdominal examination is soft, non-tended, no dilated veins in lower abdomen, no lump palpable. On CVS examination is normal, CNS examination normal, respiratory system is also normal. Summary,
Hmm.
a 29-year-old male machine operator by profession presented with complaint of dilated veins over right lower limb for 3 years and left lower limb for 1.5 years, aggravated by prolonged standing and relieved by lying down with no history of any intervention. On examination of right leg, there are dilated veins along medial aspect of thigh and leg and posterior aspect of leg with right saphenofemoral junction incompetence on Brody Trendelenburg test and Boyd perforator incompetent on multiple tourniquet test with Schwartz test positive. In left leg, there are dilated veins along left medial aspect of leg with left saphenofemoral junction incompetence on Brody Trendelenburg test. There is pigmentation present over bilateral ankle. My diagnosis on right leg, it is a varicose vein of primary etiology involving the great saphenous vein with saphenofemoral and Boyd perforator incompetence and pigmentation with no other complications. CEP classification C4A, etiology primary, anatomical superficial and perforator, and pathology reflux. And left leg, varicose vein of primary etiology involving great saphenous.
Forget the left leg for the time being.
Yes, ma'am.
Hmm. Is varicose veins the diagnosis? Or
No,
varicose veins is
no, ma'am.
presentation of some other problem?
Presentation of some other
What is it? What is that some other problem?
chronic venous insufficiency.
Hmm. So your diagnosis is chronic venous insufficiency, isn't
Yes,
it? It is not varicose veins. You are not a lay person. No?
yes.
And how do you tell us about C part of CAP?
Ma'am, according to the new classification, C0 is no.
No. How do you describe the C part of CAP? Only
Ma'am,
as C4A?
clinical from all the findings that are present clinically, we will mention.
So tell us all components of C.
Yes. Ma'am, C1 is telangiectasia or reticular veins.
In this patient, which components of C are present? You
Ma'am,
have to tell us all.
C2 and C4A.
What is C2?
Ma'am, varicose vein.
Varicosities.
Yes.
Then
Ma'am, C4A is
C3 is?
edema.
He has no edema according to you.
Yes, ma'am.
No edema?
No, ma'am.
Okay. Then C4 includes?
Ma'am, C4A includes pigmentation and eczema.
So skin changes. C4 includes skin changes.
Yes,
And
ma'am.
skin changes include?
Ma'am, pigmentation and eczema and
Pigmentation, eczema, what else?
lipodermatosclerosis and corona phlebitica.
Hmm. Can you explain the terms? What is lipodermatosclerosis?
Lipodermatosclerosis is due to chronic inflammation and fibrosis of the skin and subcutaneous tissue. It is a champagne bottle shaped uh, appearance of the leg.
Hmm.
And
And corona phlebitica?
there will be fan-shaped telangiectatic veins present over the ankle region.
Hmm. So what does the patient have? Only hyperpigmentation?
Yes, ma'am.
Okay. Dr. Modi, please. No, please ask him the questions.
Yeah. So what you said C, you said CEAP classification. So what are the other C stages?
Sir, C1 is C0 is no identified no findings. C1 is telangiectasia and reticular veins. C2 is varicose vein. C3 is edema. C4A is pigmentation or eczema. C4B is lipodermatosclerosis. C4C is uh, C4 is corona phlebitica, and C5 is healed ulcer, and C6 is active ulcer.
Okay.
And for your information, there is addition. If there
Yes,
are
ma'am.
recurrent varicosities, then they are included in
Yes,
C2R.
C2. Yes,
If there is a recurrent ulceration, it is C6R.
yes, ma'am.
You should know that. Hmm. So that is your diagnosis, and your diagnosis should mention all C components. So your patient has got varicosity, so he has
Yes, ma'am.
C2. You say there is no edema, so there is, I mean, C3 is absent. So your diagnosis should include C24A.
Yes, ma'am.
Okay, go ahead.
What is the difference between chronic venous insufficiency and chronic venous disease? Is there some difference?
So in chronic venous disease, there will be uh, stasis of blood, and it results into a venous ulcer, which is limited to the skin and subcutaneous tissue. Whereas in chronic venous insufficiency, it may extend to the deeper part.
No. Uh,
Yes,
there is
madam.
no, I mean, chronic venous disease includes the whole spectrum from, if we restrict ourselves to C, from C0 to C6R, everything is included. While chronic venous insufficiency includes
C0.
everything from edema to C6R. Okay, that is very clear evidence of venous insufficiency. But actually, now recently, people have been thinking that we should not be differentiating between these two, because even telangiectasia and spider veins or reticular veins are now considered as definite indications of future development of venous insufficiency. So there is a recommendation now that we should include all these under chronic venous insufficiency.
Yes,
And what is the difference between telangiectasia, reticular veins, and varicose veins?
so the difference is between due to the difference in the diameter of the vessels. The vessels less than 1 millimeter are termed as telangiectasia, and 1 to 3 millimeters are termed as reticular veins, and more than 3 millimeters are termed as varicose veins.
Okay.
Is it only size or the location also?
Um, Location and the elongated
Location in sense the layers of the skin.
yes, ma'am.
So what is it?
Ma'am,
Where are reticular veins situated? Where are
the
telangiectasia situated? And where are varicosities situated?
varicosities are situated in the subcutaneous plane,
Hmm.
and telangiectasia and reticular veins are in the superficial skin.
So,
Hmm.
skin includes what?
Dermis in the dermal vessels.
So there is epidermis and dermis.
Yes.
Superficial skin. So madam is asking telangiectasia are in different layer.
In the dermis, telangiectasia and reticular.
Reticular veins are in the dermis. I agree. Varicosities are in
Subcutaneous.
subcuticular plane. I agree. But where are
Telangiectasia.
telangiectasia situated?
Epidermis.
Deeper layers of epidermis.
Yes.
Hmm. Okay, what do you plan to do with him now?
Ma'am, I'd like to confirm my diagnosis by doing a duplex ultrasound
Hmm.
and then plan surgery for the patient.
So duplex ultrasound you write down and the radiologist will give a report that femoral artery is normal, femoral popliteal artery is normal, dorsal asperatus is normal.
Yes.
Do you want this information?
Yes, ma'am.
Yes. But what this is about arteries. What particular information about arteries are you interested in?
Ma'am, patency, distal patency of the arteries
And
and also the veins.
are you interested in ankle brachial pressure index?
Yes, ma'am.
Why?
What is that?
And
Ma'am,
why?
it is the difference it is the uh, ratio of pressure index, pressure between the lower limb and the upper limb, and we need to measure it to it will change our line of management, because after surgery, if there is critical limb ischemia and we apply bandages or different intervention, it may result into limb loss of the.
Okay, so this is arterial pressure you are talking about, and you should specify that. Hmm?
Yes, ma'am.
So what is the normal ABPI?
Some more than 0.9.
0.9 is normal. And so you will ask for venous Doppler, you said, but you have to write down specifically, na, Pal, that you'll
Yes.
ask for venous Doppler, venous duplex Doppler. Otherwise, the radiologist will do arterial Doppler.
Yes.
So you have to specify.
Yes.
And what else will you specify when you ask for a venous or Doppler ultrasound?
Ma'am, to look for deep venous thrombosis
No,
or
no, no. That
superficial
he will see once you
They
write
will
down,
look.
Pal,
What else?
position. You have to tell that radiologist.
in standing position.
Hmm.
Yes.
To do the ultrasound.
Hmm. And
And to look for incompetent perforator.
have you seen Doppler reports?
Yes, ma'am.
What do they give you in Doppler report?
Ma'am, they comment on the varicosities, superficial varicosities, the competency of the sacropfemoral and sacropopliteal junction, if there is a vein of Giancomini present or not, and the in position of the size and position of the incompetent perforators.
Hmm. And do you want to know size of or diameter of the vein which is refluxing?
Yes, ma'am.
And how do you know that the vein is refluxing?
Ma'am,
Looking at the Doppler or the plate that is provided with the report.
if the reflux is seen for more than 0.5 seconds,
Hmm.
then we can say it is the
So how do
refluxing.
you know that there is reflux?
Ma'am, by colored Doppler.
So what does the color Doppler show?
See, ma'am,
You said you have seen the report, no?
yes, mostly, ma'am, away from the heart, it shows a bluish color. Sorry,
Away
ma'am.
from heart is
Away
blue.
from heart it shows red color, and towards the heart
Oh,
it shows blue color conventionally.
oh.
So by looking at the color gradient, we can look for the direction of flow of blood from the superficial to the
So
Yes, color change.
okay, let me give you one information that you can change the direction and you can change the color.
yes, ma'am.
So what is more important for you to see, the color or something else?
From direction of
Besides, direction, how do you see? What is that called as? That is
velocity.
called spectral pattern. You see a
Yes,
kind of graph, isn't it?
yes, ma'am.
So that is called a spectral pattern. Why I am telling you this is it is extremely important that you look for the spectral pattern and a change in the direction of the spectral pattern. Because
Yes, ma'am.
often the radiologist doesn't give it to you and you don't look at it. Don't look at only color.
Yes, ma'am.
So you must specifically, when Dr. Modi told you that you ask them to look at the venous system and in standing position, you should also tell the radiologist or write in your note to the radiologist that please send spectral pattern recording
Yes,
because
ma'am.
that is more important.
Yes, ma'am.
And that is the recommendation for getting Doppler done of venous system.
Yes, ma'am.
Okay, go ahead. So what is the finding in this patient?
Ma'am, there is right saphenofemoral junction incompetence with
Hmm.
Boyd perforator incompetence.
Hmm.
I mean, Doppler, they have mentioned there are 4 incompetent perforators.
Okay, let's not go into incompetent perforator details because we can talk just about that. Hmm? Okay, then
And ma'am, there is a pigmentation of
that pigmentation you see on Doppler.
no, ma'am.
Then what other investigation do you want to do?
Ma'am, the routine blood test for anesthetic fitness for
Hmm.
testing the patient for surgery,
Hmm.
which includes the complete blood count, the
Hmm.
renal function test, PTINR, and the viral markers.
Acha, PTINR is routinely done in all the patients, is it?
No, ma'am. For high risk patient, old age patient, or patient who is having history of coagulation disorder, or patient on blood thinners, old age patients.
Mm-hmm. Okay. What about why should the patient be on anticoagulant? Not this. You're talking about some other patient, is it?
Yes,
Hmm. Okay. But are you interested in getting ECG and X-ray chest done?
yes, ma'am.
Oh, that is more important, na?
Yes,
Now this patient is 29 years old, but you are talking about elderly patient all the time, huh? That you will
yes,
ask for PTINR. Then in elderly patient, all the more reason that you must ask for ECG and X-ray chest.
yes, ma'am.
Why? And you may get an LFT done besides renal function. Why?
Ma'am, to check for the general condition of the patient and if there is an possibility of thrombus or embolism is.
See, your patient is young. You are saying that he doesn't have edema, but often patients with venous problem will have edema. And what are the other causes of edema? You
Most
always
common.
have to look for any other factor which would cause leg edema.
Yes,
And
ma'am.
which are the factors that can cause leg edema besides venous problem?
Cardiac failure and cardiac causes
Oh,
can
oh.
cause renal
So
edema.
cardiopulmonary causes,
Yes, ma'am.
liver function, renal
Yes,
function, patient on different antihypertensives.
yes, ma'am.
Which antihypertensives can cause edema?
And calcium channel blockers.
Yeah, so you must ask the history. If patient is known hypertensive, you must ask the patient which antihypertensive is he taking.
Yes, ma'am.
So don't just look at the leg and send the patient to radiologist. Look at whole of the patient. You will find so many things.
Yes, ma'am.
Go ahead.
Yes.
So are all investigations okay?
So
Yes,
your
ma'am.
patient is fit, everything
Yes.
is fine. Then what are you going to do?
So in our center, we post the patient for saphenophrenia flush ligation with GSV stripping and perforator ligation.
Great. How do you do it?
Ma'am, first we send the patient to radiologist for marking of the saphenofemoral junction and the perforators, and then under spinal anesthesia, we put a 1 to 2 centimeter incision, transverse incision in the groin region, and then we skeletonize the great saphenous vein, and then we tie the tributaries. First, we tie the
Hmm.
tributaries, and
Hmm.
then we ligate the saphenous vein and cut it, and then in the lower part also we
So name the tributaries.
laterally it is superficial inferior epigastric and superficial circumflex iliac veins, and medially superficial external pudental and deep external pudental, and distally we sometimes we can see accessory GSV and posteromedial distal branch also.
Now here there is no question of you seeing. You should be knowing it beforehand. You're getting a Doppler done, no?
Yes, yes, ma'am.
So that radiologist is supposed to tell you if there is accessory saphenous vein. I mean either anterior saphenous vein or posterior saphenous vein.
Yes.
Hmm.
Most commonly we tie the lateral and the medial branches
Hmm.
distal to the close to the saphenofemoral junction and the vein, and then
Hmm.
we pass make an
What
incision.
precaution do you take when you ligate the vein at junction?
Um, we don't leave extra. We don't like it distally or keep a portion of the vein there. More length of the vein.
Hmm. And most important, you shouldn't pull the vein and ligate.
Yes,
Then you will ligate a part of the circumference of the femoral vein.
yes,
So don't keep a pull on the vein when you're ligating it at the junction.
yes,
And what about the incision? Your incision should be as small as possible with as minimum dissection as possible. Otherwise, you are damaging lot of lymphatics and a significant number of patients develop. And then how do you strip the vein?
Ma'am, we keep another incision in the lower part of the vein, just below the knee, uh,
Hmm.
and we make a venotomy, and then we pass the stripper from above downwards, from the thigh groin to the knee, and then we strip the vein from above down direction.
What type of stripping is recommended? Do you know types of stripping the vein or the methods of stripping the vein?
No, ma'am.
No? When you remove the vein, how does it come out? Inside out
Yes, ma'am.
or outside in?
Inside out.
So, what is that method called as?
In invagination of.
Ah, so that is invagination method, isn't it?
Yes, ma'am.
So that invagination technique is better than the previous way of keeping that. Do you still use those strippers? Which type of stripper do you use?
Ma'am, there is an end. At the end, there is an bulk. Uh,
Hmm.
we fix that to the stripper and then we pull the stripper in.
Hmm. So then is it invaginated if you keep the uh, bulb out, as you're calling it?
No, ma'am.
No. So for that, you have to have a very small thing which gets pulled inside the vein, and then the vein is pulled by invagination. What is the advantage of invagination method?
Ma'am, it decreases the recurrence and neovascularization and decreases the local hematoma and bruising.
And
Damage to the nerve.
yeah, less chances of damage to the surrounding structures, which includes nerve also,
Yes, ma'am.
and better avulsion of the tributaries.
Yes, ma'am.
Okay, I think Dr. Modi will ask you questions about other methods. I've talked too much.
So which are the, if suppose patient does not want a surgery or a scar, then what are
Yes.
the other methods of doing this patients?
So we can do endothermal ablation by radio frequency or laser ablation of the vein.
Okay. So which laser machine is used for endovenous laser treatment?
So there is usually wavelength of 1470 nanometers, and it consists of a glass fiber.
Which fiber it is used, Dr. Pal? How many
Uh,
types of fibers you know of laser?
so one is made up of glass fiber.
All are made up of glass. What
So
Or
are
more likely
three
silicon.
types are three types are there with
three types? Correct. What are
one one at the end, at the tip, one at the tip, and one variety or in the sideways.
so, Dr. Pal, there are three types. One, as you said, is a bare fiber. Second is a radial fiber, and
Ye-
third is the conical fiber. Okay.
Yes.
So which fiber is good for doing a laser varicose veins?
So
Of these three,
radial.
radial. Why?
So we can apply it to a wider area and simultaneously ablate the sideways and focus. We can avoid focusing the thermal energy at a single point, which can injure the vein or surrounding structures.
So have you seen a procedure like this before?
No, no, sir.
No. Okay. So what are the other, as you said, is uh, radio frequency ablation. What are the other methods you know?
So we can do subfacial endoscopic perforator ligation.
That is for perforator. I'm asking you for the truncal veins. What are
Uh,
other options?
so, we can good give a sclerotherapy mm, to the patient.
Okay.
To simplify things, you classify these methods into two categories: thermal ablation and non-thermal ablation.
Ablation.
So thermal are laser, radio frequency, microwave, steam. They all use heat
Where
basically.
heat is given, and non-thermal is where heat is not given. Okay.
Yes.
You know any
Yes.
non-thermal ablation?
Uh, so sclerotherapy, using sclerogen,
Mhm.
and
Yeah.
recently there are mechanical and chemical ablation techniques are being.
Hmm.
Yes.
Very good. What else?
Glue, cryoclinic glue.
Yes, cyanoacrylate glue. Very good. So what for a truncal vein, you said you will use a sclerosant. Then do you know what is the percentage of sclerosant used for a truncal vein? Are there concentration different for all veins or they are the same?
No, so they are different. Mostly we use 0.5 to 1% of the sclerosin.
What is used for as sclerosant?
Sodium tetradecyl sulfate or
Hmm.
polydocanol.
No, it
Hmm.
is not or. It is sodium tetradecyl sulfate is one and second is polydocanol.
Yes, sir.
Okay.
Yes.
So as you said, the concentration is not right, what you said. So if you are using for a truncal vein, then you need to use a 3%.
Yes.
Okay.
Yes, sir.
And if you use it for telangiectasias and reticular vein, what is the concentration? And if you use it for a tributary, what is the concentration? Are you aware of that?
No, sir.
Okay. So if you are using it for telangiectasias and reticular veins, the concentration is around 0.25. Okay. And
Yes.
if you are using for little bigger reticular vein, it is 0.5. And if you are using for tributary, it is 1.5 percentage. And if you are using it for truncal vein, it is 3%.
Yes.
Okay.
Yes, sir.
So sclerotherapy again is of two types. What are they, you know?
So we can simply inject the sclerosin, or we can give the sclerosin in the form of a foam.
Yeah. So this is called as liquid sclerosant or foam sclerosant. What
Yes.
is the advantage of using what is the concentration for foam sclerotherapy?
So 1:4 or 1:5
Okay.
using the foam
So
sclerosin.
what, correct. So what is the ideal, what is what ideal way to inject a foam sclerotherapy? It's
Uh,
to use what?
so we prepared the sclerosin by using two syringe and a three-way cannula in the ratio of 1:4 or 1:5, and it should
So
be used within the first 2 minutes. And
2 minutes. Too long. The foam will disappear.
uh, we do not inject more than 10 ml of the sclerosin.
I think Dr. Modi wants to know what is the ideal way of giving foam sclerotherapy.
so
Do you
what
use
Under
do you use some help for that?
USG guided.
Ah, so it is ultrasound guided foam sclerotherapy. Okay.
Yes.
okay.
I
And
think I think it knows a lot about methods.
yeah, so
What
the
are the
method,
complications of
what is
surgical
the method
procedure?
called as this method what you
Pardon.
described is called what name?
Tertiary.
Very good, very good. Okay. So now madam's next question is what are the complications of sclerosis?
I'm going back to basics, complications of surgery.
Complications of surgery first.
Ma'am, there can be edema, so skin necrosis and nerve injury and bleeding.
Hmm. Okay. These are probably the major ones, kind of. But with, I mean, besides that, patients can have ecchymotic patches.
Yes.
You have stripped the vein, isn't it?
Yes,
So
ma'am.
along the pathway, you can have ecchymotic patches. Patient can get infection
Yes.
along the track in the incision site of SF junction ligation, and of course, nerve
Which
damage.
nerve?
saphenous nerve in the in great saphenous vein stripping.
And for SSV, which nerve?
The sural nerve.
Very good.
Have you seen any SSV, any surgical procedure done for SP junction reflux?
No, no, ma'am.
Oh, ma'am, there's a question in chat box that how do you decide whether to subject the patient to EVLA or stripping? So you can
Depends on what you are familiar with.
Availability. So
Sorry?
it depends on what is your expertise. It depends on who is the patient,
And
where are they doing. So if it in government hospital, surgical stripping is a good option. If you have in private, then you
I differ.
do EVLA. And
I
second, I'll
differ.
just finish. If the
I,
size of the GSV is more than 15 millimeter, then surgical option is better. Yes, madam. Tell me.
I think for patients in government and municipal hospitals, endovenous ablation is the best option because these are the patients who are from poor socioeconomic class, need to go back to their work as early as possible. So, the best option is endovenous ablations.
So as I told you, if the availability is there, then
Yeah.
definitely endovenous ablation scores much over surgery. But if availability is not there and the cost is a constraint, then surgery is also an option.
Or like some countries, people from some other countries tell me, in some countries insurance doesn't allow endovenous ablation, which is rather surprising. But then they're forced to do surgical procedure.
And second is the size of GSV. If it is more than 2 centimeter, then a surgical option is a better option.
Modi sir,
Yes, sir.
there are two things I wanted to ask. One is what is microphlebectomy? Sometimes this word is used. Is there any role of that or is it same as endovenous, whatever it is?
No, sir. So microphlebectomy is like ambulatory phlebectomy only.
Okay.
But you are using a small incision. There are hooks which are there, the Osh hooks, and so these you give a very small incision and remove the tributaries. That
Okay.
is microphlebectomy.
Yeah.
Oh,
So, while if you remove the trunk vein, then you can't do a phlebectomy. It is not possible. Why, Pal? You can't do a phlebectomy for a truncal vein. करने के लिए तो you can do anything, but why it is not advised? So the more important question is, how do you know on sonography that it is a GSV or SSV? Pal,
So the location of the vein,
what location?
the compartment, which compartment the vein is lying, and the draining, where the vein is draining into.
No, so the most important question, Dr. Pal, is how do you know this is GSV or SSV on Doppler test? So that is something called as Egyptian eye. Okay, so GSV and SSV are always in a fascia. Okay, and once they come out of fascia, you can do a phlebectomy because they are outside. But if they are inside the fascia, then it is difficult to do a phlebectomy. And therefore, whenever it is in the fascia, outside the fascia, you can do a phlebectomy. And when you use a small incision around 1 to 3 millimeter, then it is called as microphlebectomy. Okay.
Dr. Supe, just
so
to
previously they used to
add,
put multiple small incisions and used to remove those segments, right?
Yes.
Outside fascia. Yes, madam.
Yes.
um, generally, if the uh, refluxing tributary is larger than 5 millimeters in diameter, uh, closing it with sclerotherapy can cause some troubles unless you really give good compression locally and patient continues to use compression appropriately because it's a large size vein.
Yeah.
So in such big size tributaries, phlebectomy is a better choice so that in one sitting you clean up the leg completely.
Fine. Second, I wanted to ask you, there were previously people used to do wall repairs. Now, I don't see this kind of a role today with so many other modalities which are coming, right?
Uh, I had the opportunity to work with Dr. Sheshadri Raju at Mississippi, who regularly used to do valve repair, particularly for deep venous valve reflux. Because for superficial veins, there is no indication for valve repair. Superficial veins can be sacrificed when the deep veins are open.
Okay.
But valvuloplasty
Hmm.
or was particularly done for deep venous
Reflux.
valve incompetence or valve replacement using axillary venous
Oh,
segment with a competent valve. Uh, the efforts are at present, clinical trials are on for creating a valve in situ
hmm.
using a kind of equipment that has been developed that you put it in the vein
Hmm.
where the vein is normal, or rather the endothelium is normal, and the endothelium is folded using that particular equipment so that a new valve is formed, but it is still undergoing trials and not available yet for patient treatment. So valve
Sure.
reconstruction is done, but basically it is for recreating the deep venous valve segment so that we can take care of deep venous reflux,
Sure.
not for superficial venous.
Thank you. Thank you for that.
Madam, there's one more question in the chat box ki, for young patients, since they have the whole life ahead of them and recurrence rates of varicose veins, any modality are there. So, what is the comparison between conservative management or surgical management? Matlab, whether they should just go on with conservative management and wear stockings, or they should go and opt for a surgical modality.
Um, the data suggests that uh, the recurrence rate is higher after surgical procedure, while recurrence rate after thermal ablation is 3 to 5% at 10 years. The recurrence rate for glue ablation over long period is not yet available because glue ablation itself is a relatively recent kind of development. Uh, One can certainly use compression stockings and do exercises and try and maintain the weight uh, so that they can continue with compression stockings. But most of the patients cannot comply with compression stockings over long period. And everyone knows by this time now that uh, venous insufficiency is a
Chronic
definitely
progressive
progressive
disease.
condition. So someday or other it is going to reach the next stage. So generally patients who already have skin changes are certainly recommended definitive treatment. And patients who are young and don't want surgery at that point of time and are still maybe not having edema, having few varicosities, can continue with compression stockings for as long a period as the things are going on all right. But my observation, and of course, the literature also tells us that this is progressive and someday they are going to require treatment. The logic behind treating these patients is mainly as the age advances and patients develop other comorbidities, then treating them, or they develop venous ulcer and then treating them doesn't give you as satisfactory results as one wishes to, because once venous ulcer develops, the recurrence rate of venous ulcer is to the tune of 50%. So you are actually making the life of elderly patients miserable by not treating them at younger age. But then let me put one thing very clearly, Priya, at this point, that there is no point in closing a normal vein, certainly. We do need veins as conduits for different purposes. Maybe conduit to replace an artery, maybe conduit for
Has
coronary bypass surgery. And just treating a vein just because it is there is certainly not an indication for closing it. Because I do see a lot of patients who have undergone bilateral GSV, SSV, all possible veins ablated. That is not the thing to be done. It is dangerous for the patient also because those normal veins are needed. Every tissue in the body is there because it is necessary, not just because nature thought that it should put something there. So please don't ablate normal veins. They are needed.
Yeah.
What I gather, what ma'am you are trying to say, and which is a lesson for the students, is that whenever you see a Doppler report and it says dilated veins, that is not an indication for
That
any
is not.
intervention. You have to
Reflux is
prove
an
insufficiency, you have to prove reflux.
yes.
That is an indication. So just a
That is why
dilated
I
vein
asked
is not
for
an indication.
yes. That is why I asked for a spectral plate
Yes, ma'am.
and not just the size of the vein. Size is immaterial.
Yes, ma'am.
But as the question was, if the size of the vein is large, more than 7, 8 mm, and there is reflux, then there's no point in asking a patient to undergo stocking. I, I would advise them to undergo some kind of intervention.
True.
Because as a patient, if he lands up C4, C5, C6, then he has a lot of problems, and then there is no way he can, the recurrence chances increases in those patients. But if they are early picked up, the recurrence chances are very, very less.
Yeah.
Agree.
And stocking, you advise.
So your voice is breaking in between.
Hmm.
Rajan sir, your voice is breaking actually. Dr. Pal,
Yes, sir.
you have any questions which you want to clarify with?
Different kind of stockings, you are aware? Different kind,
So can you repeat
you
your
have
question? Your voice was breaking up.
doubts, any doubts, or you want to ask any questions to us?
That's what exactly I said.
No, sir.
Any clarification you want to ask there? I mean, you can, this is the right opportunity to really ask. Any question which you have in your mind, which you want to answer, if, I mean, want to get an answer, I'm sure here they can give you.
No, sir.
Sure.
Yes, sir.
Okay. I think, thank you.
Okay.
Thank you. Is there anything, anybody else has any question? Then I think if there are no questions in the chat box, we can really call it a day. I think wonderfully conducted. And I think I also learned a lot, Madhuri Madam, as usual, from you and Rajan.
Harikai.
Okay. No, it's some of the new concepts. I think I was not updated. Actually, that's something which was always enjoyable. And thank you so much. You, I think, Pal, you have done quite well actually. But I'm sure the small other knowledge, I'm sure, will help you to do better.
Yes.
Thank you, Gauri madam. Thank you,
Thank
Modi
you.
sir.
Thank
Thank
you.
you.
My
Thank you, sir.
pleasure.
Yeah.
Thank you so much.
Thank you, Dr. Spay.
Good night, everyone.